Good morning, everyone. My name is Paola Neri. I'm a clinician scientist at the University of Calgary. Today, I've been asked to discuss with you the factor linked to resistant to anti-BCMA therapy in multiple myeloma. And no doubt, this is a very important question since we have several approaches that target BCMA. These include CAR T, include T-cell engager. And I think even if we all recognize that we have a lot of impressive results using this therapy in our patients, mostly in the relapse refractory setting, we all have some patients that do not respond to this therapy, or initially they respond and they progress. So I think for us as a scientific community, it's very important to learn what causes resistance, because we want to understand how to prevent this mechanism from happening, or also eventually overcome these causes of resistance. Now, I'd like to share with you what our lab in the last 5 years have been working on. And I think this finding have answered several of these questions. So first of all, we have collected in the last 5 years a patient sample collected from patients treated with anti-BCMA CAR T-cell engager. And what we are looking at is one side, what changed in the tumor in patients they are sensitive to this therapy and the one resistant to that. But also we have looked at the non-myeloma components, so all the T-cell factors that may influence this therapy. And because of that, we have now a better sense what really causes resistance to this therapy. No doubt, the first and most important factor linked to resistance is the loss of the antigen, what we call antigen escape, that we're seeing more and more often following therapy with anti-BCMA. When I say antigen escape, this can be due to a biallelic loss of the target, and we have reported few cases in a recent publication in Nature Medicine, where we have seen patients progressing because they lost the 2 copies of BCMA on the tumor. But more frequently, we are seeing what we call another antigen escape due to monoallelic loss of the antigen in one end, but the acquisition of new mutation in the extracellular domain of BCMA. And specifically, we report the development of this new mutation in a very specific hotspot of BCMA extracellular domain. And these mutations are R27, S34, S30. And what we have actually confirmed that this mutation seems to acquire more often following therapy with T-cell engager, in around 40 to 50%, and around 5% following therapy with CAR T. So the first question is, why is this difference? I think we believe that is because with the CAR T, we just give one-time event and the cells can actually respond to therapy or not. But with the T-cell engager, the continued therapy may select cells that may acquire this mutation over time. So definitely antigen escape is what we notice is the most driver of resistance in myeloma. But this is not the only cause. We have around 20% of patients that they are resistant to this therapy because they have a T-cell phenotype, which is a bit different than the sensitive patient. What I mean by that, they express mostly T-cells. They are effector, terminal, or more important, they are exhausted. And when I say exhausted, these are T-cells that they actually not able to proliferate much, and they are definitely not able to persist in patients because they have some specific markers, specifically checkpoint inhibitor. They don't express CD28. They express CD57, and this is work we have recently published in a Cancer Cell paper in 2023, where we have looked at what is unique in the responder and non-responder post-therapy with an anti-BCMA T-cell engager. And what we have observed is that the T-cell exhaustion was the main driver of resistance, because this patient, if they have a baseline T-cells in the bone marrow, they have this exhaustion profile. They unfortunately are not able to respond, and this is the cause of failing of their therapy. So 20% we can attribute it to T-cell exhaustion. What about the rest? So we can say probably the rest can be due to the composition of the bone marrow microenvironment. We know in myeloma is quite immunosuppressive, so we're learning now that the amount of dendritic cells or also macrophages present in the bone marrow of this patient influence the response to therapy. And there is beautiful work done by Madhav Dodapkar that actually look at the composition of all the elements of the bone marrow microenvironment of patient progressing on CAR T. And this shows that if there are macrophages more M2, so more pro-inflammatory, less anti-tumor, patients don't respond to therapy, or if there are a lot of dendritic cells, which we know are the cells presenting the antigen, these are patients that they actually respond to therapy. And lastly, I would like also to add that there is a specific subset of patients where we don't see any effect of this very effective therapy. These are patients with a very high tumor burden or also extramedullary disease. And in this patient, I will argue that there are additional factors, including soluble BCMA, or also the extramedullary component, which is a bit difficult for this therapy to reach. They really require a much more understanding from our end to really overcome this resistance. Nevertheless, we are excited about this therapy, but I will say as a community, we should definitely start interrogating the tumor as well as the T-cell component, the bone marrow microenvironment of this patient, because by just integrating the two, we can really personalize the therapy, and we can really understand if the patient we have in front of us in the clinic is a good candidate with therapy. And with that, I'd like to thank you for listening. Thank you.